Recent clinical trials, I think, have now defined more clearly lines of treatment in metastatic esophagogastric cancer. And we now have randomized trials clearly indicating a benefit for patients for moving on to second-line treatment after progression on first-line therapy. We had some pivotal early randomized trials that indicated that after progression on fluorinated pyrimidine platinum, we see a survival benefit for patients getting a docetaxel versus best supportive care alone from the British data. And then Japanese trials looked at studies allowing patients to get either paclitaxel or irinotecan versus best supportive care. And those studies also showed a survival benefit for second-line chemotherapy. Now in second line, we have the advent of ramucirumab. That really was a game changer in the second-line treatment of metastatic esophagogastric cancer. The pivotal Rainbow trial in patients progressing on first-line treatment assigned patients to paclitaxel alone weekly or paclitaxel plus ramucirumab. That trial showed an unequivocal benefit for ramucirumab. There was an improvement in response rate that was clinically meaningful, an improvement in progression-free and overall survival with a median overall survival of 9 months, which arguably approaches to what we achieved with first-line FOLFOX. So paclitaxel ramucirumab is now the standard second-line therapy in esophagogastric cancer and is really should be the control arm of any future trials trying to evaluate other treatment options in the second-line setting. Irinotecan we would really reserve for third-line treatment, and we'll talk about this later, but immunotherapy drugs really have shown benefit in the PD-L1 positive patients in the chemotherapy refractory setting beyond second or third line treatment.
My second-line therapy of choice for patients with metastatic gastric cancer is ramucirumab plus paclitaxel in patients who are not taxane pre-treated. In Germany and in many parts of the world, taxane pre-treatment is increasing because taxanes has been proven to be efficacious in the neoadjuvant setting or in the adjuvant setting. So in these cases where patients have received taxane, it's important to look how long time has passed until since the last administration of the taxane. So in patients progressing shortly after a previous taxane, we tend to use irinotecan in the second-line treatment.
In general, the drugs used in the first-line treatment are not used in the secondary treatment and beyond. Most of the time, it is because they have built up a tolerance. It is important way to link the second and third-line treatment sequentially by proper timing using the effective agents. Typically, secondary choices, we often use paclitaxel plus ramucirumab or nab-paclitaxel plus ramucirumab. And we rarely ever perform ramucirumab monotherapy.
There is a number of cytotoxic agents that has shown some activity in the second-line setting in gastric cancer. These include docetaxel, paclitaxel, and irinotecan. And there have been multiple randomized trials with the different quality standards showing that these compounds do have activity. However, overall survivals have been relatively short, with being 4 to 5 months with these agents. So overall, I think these agents are valuable, and we do use them in different lines of the treatment, but still it's important to highlight that the addition of ramucirumab to paclitaxel is superior to paclitaxel alone, where paclitaxel is not superior or non-inferior to the other drugs like docetaxel and irinotecan.